presentation about acute heart failure and management of acute heart failure. So now we can say thank you everyone.
شكرا دكتور محمد ربيع. وبس انت محتاج التون بتاعك بطيء شوية، مع النت اللي بتقطع ضيعوا قيمة شوية من المحاضرة، بس هي محاضرة ممتازة وتو ذا بوينت وكونسايز. معانا الدكتور حاتم سليمان.
شكرا.
ويلكم دكتور حاتم سليمان. شكرا انك اديتنا وقتك وهتقول لنا محاضرتك قيمة عن الفاليو اوف ايكو في الهارت فيلير. دكتور حاتم سليمان اساسا من جامعة اسكندرية، وكان من الاول يعني ممتاز، بس فضل انه يكمل وعمل رحلة كفاح لحد ما بقى واحد من اشهر الكونسلتنت في الاي سي يو سبيشاليتي الترا ساوند في جميع مجالات الجسم والايكو سبيشالي، وله كتاب مؤلف فيه باب كبير كان حاطط اسمه قريب، ونفتخر بوجوده معانا النهارده. وهو الحقيقه بقى له 3 سنين بيجي كل سنه بيدينا محاضره قيمه. وانا حتى في دكتوره بتعتذر بتقول لي يا دكتوره فاتن فريد انا في الحرم كان نفسي احضر محاضره الدكتور حاتم لانه ممتاز ومنظم وتو ذا بوينت. فاحنا بنرحب بالدكتور حاتم سليمان وهنخليها كلها بالانجليزي. انا شايف في 3 من عنده في الاسم من انجلترا هيحضروا، فهيبقى المناقشات كلها بالانجليزي. اتفضل يا دكتور حاتم.
أولا السلام عليكم دكتور حسن. شكرا جزيلا، يشرفني أكون مع حضرتك و a real pleasure and honor to be with all my colleagues في البلاتفورم دي. ودكتورة فاتن بقى تدعي لنا دعوة حلوة كده إن شاء الله من عندها يعني. وعايز أشكر دكتور محمد ربيع، محاضرة رائعة جدا، سلايدز جميلة واضحة، perfect choice of colors. يعني it's a great presentation الحقيقة. طبعا it would be nice if it can be split into 2 lectures لأن هي it's a very comprehensive one. ف my only comment يعني my only suggestion إنها ممكن تبقى تتعمل على محاضرتين. Each one will be about 25 minutes لأن there is a lot of things you can say about this lecture, but it's really wonderful, great, and you covered from the diagnosis to the management, even you covered mechanical support. So great job Dr. Muhammad.
ربيع سمع. دكتور محمد ربيع سمع
Thank you.
عظيم.
Great job.
شكرا، ألف شكر لحضرتك يا دكتور.
وانت اعمل بقى ستوب شيرنج سكرين عشان الدكتور حاتم يحط السلايد بتاعته.
حاضر يا دكتور. تمام. خلاص stop the sharing.
Okay, and I will share my screen. بسم الله الرحمن الرحيم. حضرتك دلوقتي شايفين you can see my presentation. Okay, can you see my presentation?
Yes. Yes, it's
yeah. احنا ان شاء الله هنتكلم على echo assessment of congestion. Maybe this is something we discussed briefly before, but I will cover more in depth in this presentation, and I will discuss the use of ultrasound for multi-organ assessment of congestion, which complements what Dr. Muhammad mentioned, because this is integral part of assessment of heart failure patients, especially in the acute settings. I have no disclosures. أنا أحب أبدأ إن يعني it's a historical bit. This is the landmark paper by the French physician René Laennec. Laennec هو اللي اخترع الستethoscope. He's the inventor of the stethoscope. And you could see it was published 1819. يعني it's more than 200 years. يعني the world, and this is the 4th pillar of physical examination, which means that we have not advanced our physical examination for more than 200 years, which is remarkable. And also mentioning the stethoscope, I think the word stethoscope itself is a Greek word, It has 2 parts. One is stethos, which is chest. The other is scope, which is to see. But actually with a stethoscope, we don't see. We just listen. So هم ضحكوا علينا. They told us lies. The stethoscope is not a stethoscope, it's a stethophone because you can only hear with it. The true stethoscope is the ultrasound, because this is the device which allows you to see the structures. And now there is a lot of evidence which advocates for ultrasound as the fifth pillar of bedside physical examination. بيسموها insonation. And that's why ultrasound has developed significantly over the last years. You could see on the left, this is the first known ultrasound machine or echo machine developed by Dr. Edler in Lund in Sweden. And you could see over the years, there is a huge technological advancement. نحن دلوقتي now we have modern machines with 3D echo, strain echo, a lot of fancy stuff. Even now we have handheld devices available in the market with artificial intelligence, with continuous wave Doppler, tissue Doppler. طبعا, this is a breakthrough. But this comes with opportunities and also with challenges, because it means that ultrasound will be in the hands of everyone. And without proper training and without proper understanding of the complexity of using ultrasound and echo in patients, you can easily make errors and you can easily cause harm by using echo inappropriately. And that's why this effort by Professor Hassan Khalid is really important, because teaching people is fundamental in ensuring safe practice. I'm going to talk about congestion enough regarding history, and I will start with a very simple, basic physiological equation, which is the equation of perfusion. We all know this equation, very important in our understanding of cardiac output. The equation is telling us that the difference between mean arterial pressure and CVP divided by the systemic vascular resistance indicates the cardiac output. And what I know from this equation is that the higher the CVP, the less the cardiac output, because cardiac output or perfusion is driven by the gradient between mean arterial pressure and the CVP. And you know what is the mean arterial pressure? It is the diastolic blood pressure plus 1/3 of the pulse pressure. And this is the marker of blood flow to the tissues, the marker of blood delivery to the tissues. That's why patients with right heart failure or right ventricular failure, you will aim for a higher mean arterial pressure. And if we normally aim in a shocked patient for a mean arterial pressure of 65 and above, in a patient with cardiogenic shock due to right ventricular failure, you should aim for a higher MAP. Why? Because these patients with right heart failure, they usually have a high CVP. Because they have right heart failure, the preload of the right ventricle is high. And if you have a high CVP, to maintain the gradient, you should have a higher MAP. And that's very important. There is already a lot of data which provided evidence that excessive cumulative fluid balance in the hospital, whether in the ward or ICU, leads to poor outcome. Not only because of congestion in the heart or lungs, but also because of congestion in the intestine, in the liver, in the kidneys, even in the brain. Because all organs which are encapsulated, whether by a capsule or by a skull, are liable to the implications of fluid overload. And this is a study which I found very interesting. It was published a few years ago by a team in the United States, a team in Montreal, actually, apologies, team in Canada. And they looked at delirium. I think for all of us working in ICU, delirium is a big problem, and no one understands why patients get delirious after ICU. So this study tried to answer a question: is there an association between fluid balance after cardiac surgery and delirium? The results were fascinating because they found that 48 hours onwards after cardiac surgery, patients who had positive fluid balance were more likely to be delirious, which I find very fascinating because that could indicate that delirium is caused by congestion, by fluid overload, whether it is liver congestion with release of chemicals in the blood because liver is congested, or because of brain congestion. Maybe patients might get subclinical brain edema from fluid overload and they become delirious. So this is a very interesting one. And the study was retrospective, and the same team performed a year later a similar prospective study and they got the same results. We also all studied and learned very well. We always talk about the Frank-Starling curve. Who doesn't know the Frank-Starling curve? Very famous. It is one of the fundamental physiological relationships, the relationship between preload and stroke volume. The Frank-Starling curve here is the red curve, which indicates how much the stroke volume will change depending on augmenting the preload, depending on the cardiac function. But no one told us about another curve, another very important curve, which is the blue curve. You could see here the blue curve. I put both curves together at the same time. You have the red Frank-Starling curve, and you have the blue Guytonian venous return curve, because I want to show you what happens while you are augmenting preload. You all heard and know about preload responsiveness, which means that you want to increase stroke volume by increasing preload. But see what happens while you are still increasing stroke volume at this ascending part of the curve. And I hope you can see my cursor. Maybe I will use a laser pointer. At this ascending limb of the curve, while you are still increasing stroke volume by augmenting preload, see what happens to the venous return? It will drop significantly. And this is actually a point of harm. And this is one of the major aspects of hemodynamics which we were missing, because we should not fixate on increasing stroke volume, neglecting the implications on venous return. We should not fixate on preload responsiveness. And some of us do. Some of us like to see the VTI increasing after fluid bolus. But the issue is not only the VTI. The issue is not only the blood pressure. You should also look at the dark side for congestion. And that's why this was a landmark paper by André Dunot and his team, which quantified systemic venous congestion by ultrasound. So they looked at different parameters of systemic venous congestion by ultrasound. They examined different parameters, started from the inferior vena cava, IVC, to the hepatic vein with Doppler, portal vein, and renal vein. These are the main parameters they looked at, and they developed a score. They called it VEXUS. The score includes all these different parameters, and I will show you how to do it shortly. And also they found in the study, this study was done in patients after cardiac surgery, by the way. So this protocol was initially validated after cardiac surgery, and they found that post-operatively, patients with high score, which means severe congestion, were associated with acute kidney injury and outcome and mortality. So it's very serious. So how do we do it? This is a summary paper which I wrote with Andre. It's a 2 pages paper. You could feel free to scan the QR code. It's open access, and it just guides you towards how to do it at the bedside. For you as cardiologists or intensivists doing echo, you can do this on your own. You can simply self-learn it because it's very easy to do. So as I said earlier, you start from the IVC and then you go to the hepatic vein, you look with Doppler and then the portal vein, and finally the renal vein. In the usual way, as I'm sure you do, you usually look at the IVC in the subxiphoid window. But I actually prefer another window, which I find much more easier, which is the transhepatic mid-axillary window. I put the probe in the mid-axillary position. I hope you can see my mobile. I put it here as a probe. This is where I put the probe. Mid-axillary position, the marker of the probe towards the patient head, and that will enable you to see the liver. And the recommendation, what we learned from the protocol, is that you should not measure the IVC diameter in the long axis orientation, because when the IVC is empty, it tends to be elliptical and not cylindrical. So if you do it in the long axis, you might overestimate the diameter. So the recommendation is to rotate the probe, and you obtain, as you could see here, the short axis of the IVC. That is the short axis, and then you will ensure that you are not overestimating the diameter. So the recommendation is to get the short axis, and you get the longest and the shortest diameter and take the average. That is the best way to do the IVC diameter. The protocol is telling us that if the IVC is less than 2 centimeter or less than 2.1 centimeter, then you are unlikely to be congested. So there is no need to further proceed and do the protocol. I actually disagree with this because I see patients with a small IVC and clear evidence of congestion. So I don't exclude congestion based on a small IVC. And that's what I learned so far. Remember that IVC diameter is not only affected by preload of the right ventricle, it's also affected by the intra-abdominal pressure because the IVC is an intra-abdominal structure. So if your patient has increased intra-abdominal pressure, and this is a problem in our ICU patients, which is under-recognized, your IVC will be collapsed and they might be congested. And similarly in pregnancy, because with mid or near-term pregnancy, you're likely to have a small IVC because of intra-abdominal hypertension. So the bottom line here is don't exclude congestion based on a small IVC. The best is to proceed with Doppler and look for the flow in these structures, starting from the hepatic vein. For those of you familiar with echocardiography, you usually do the hepatic vein, which is usually part of the assessment of RV preload. The hepatic vein looks like this. As I said, I do it from the mid-axillary orientation with a marker towards the head. And the hepatic vein should be seen draining into the inferior vena cava, like this. And when putting color Doppler onto the hepatic vein, the signal has to be blue, because the blue signal will indicate that the flow is going downward towards the IVC, which is the normal flow in the hepatic vein, predominantly downward, predominantly antegrade, as we describe it. And this is the normal hepatic venous waveform. We know this is the normal triphasic waveform. It has three components. It has the A component. This is the A wave. And normally this is the only waveform which is reversed upward away from the IVC. And this is normally the atrial contraction. So that's why it is the only reversal wave in non-congestive states. Because the right atrial kick is the only time during which the right atrial pressure increases if you don't have increased right atrial pressure. And that's why you have forward flow in ventricular systole and also forward flow in ventricular diastole. In ventricular systole, the flow is forward because the atrium relaxes. And in ventricular diastole, it is also forward because the tricuspid valve opens. This is exactly the same waveform we see in the JVP, in the central venous pressure waveform. Exactly the same, maybe with different naming of the waves, but exactly the same shape. And the same changes apply here and there. So when the right atrial pressure increases, the first thing that happens is that the atrium will be less able to relax, and then you will have reduction of flow in systole, so the S wave will become smaller than the D wave, and with further increase in right atrial pressure, the S wave will become smaller and smaller and smaller until reversal happens. And once you see this reversal, then the waveform changes completely. Now, if you remember, this was a triphasic waveform, A, S, and D. Now it is not triphasic anymore, it's biphasic. One big wave up and one big wave down, and this is the typical for severely abnormal hepatic venous waveform. And this is the systolic reversal. It's a classic feature of severely elevated right atrial pressure. But this does not necessarily indicate congestion. Why? Because that relies on the tricuspid valve competence. Remember, if you have tricuspid regurg, it will also impact your hepatic venous waveform, and that is the main limitation. You should not use this to assess congestion if you have tricuspid regurg. If you don't have tricuspid regurg, it will be reliable. But that is the main pitfall. So what is the solution then if we have tricuspid regurg? The solution is to get the portal vein, which is much more easier to acquire. And to me, this is the king of the protocol. If you have 10 seconds with your patient crashing, you want to answer the question of congestion, do the portal vein only. Portal vein, as you can see, it is here. I'm still in the mid-axillary window, by the way. The only thing I need to do is tilting the tail of the probe down towards the bed, because the portal vein is located slightly anteriorly in the liver. So I was able to see the hepatic vein when the probe was slightly looking posteriorly, and to get I said the hepatic, apologies. So hepatic is a slightly posterior, portal is slightly anterior. So just that tilt up and down by half a centimeter. And that will show you the portal vein looks a bit different because the wall of the portal vein is bright. As you could see, it's hyperechogenic. And if you remember, we said the color signal of the hepatic vein is blue. The color signal of the portal must be red. It is red. And I remember it as PR, so portal red, PR. This is how you remember it. And of course, it is red because the blood goes upward towards the probe. And that is typical for the portal venous flow. And also the analysis of the portal vein is much easier. I called it the king of the protocol because it is very powerful. It is not affected by tricuspid regurg. It has nothing to do with right atrial pressure because it simply reflects venous return from the gut, and it does not require an ECG. And the interpretation is much more easy. For hepatic vein, we had to look at systole, diastole, A wave, S and D. But in portal vein, we don't have to look at any complex components. We only look at pulsatility. So if the portal vein is congested, it becomes pulsatile. You could see here on the left, portal vein is normal, less than 30% pulsatile. In the middle, 30 to 50% pulsatility, which is mild abnormality. And finally, on the right, severely abnormal, more than 50% pulsatility. You could even see that the pulsatility on the right is more than 100%, because if you look carefully here with me, you will see that there is even some reversal under the baseline in that severely abnormal portal vein. And there is data which showed that in hospitalized patients, portal venous reversal like this, more than 100%, the mortality is almost 70%. So that is very scary. And I have to tell you, since I started practicing this in our hospital patients, I am surprised how many of them have such degree of portal venous pulsatility, which tells me that our patients are fluid intoxicated. They get fluids without control. And that's why this increases morbidity and mortality. And finally, the last thing to mention is the kidney. Some colleagues who already practice this struggle with the kidneys, and I will tell you why, and I will tell you how to improve your assessment of the kidneys. Remember, I'm still in the same position, the mid-axillary view. To obtain the kidney, you just need to go a bit posteriorly onto the kidney angle and tilt the probe down, and that will show you the kidney in 2D. And then you will obtain the color Doppler of the kidney. Why some colleagues struggle with the kidney flow? Because I usually perform this protocol using the cardiac probe, our phased array probe. This is part of my echocardiographic assessment. I call it now echographic assessment because it's not anymore echocardiography. It is echography, which includes the lung, includes the systemic veins. But if you do this with your cardiac phased array probe, the settings of the cardiac probe, the cardiac settings, are not optimized to show you the low flow vessels of the kidneys, because the kidney vessels are very low flow. So what is the solution? One thing to improve the image is to change the preset on your ultrasound machine, on your cardiac probe, to the abdominal preset. Most ultrasound machines and echo machines have this ability. If you are not aware, go and check your machine, and most of them will have this ability. And maybe you check the engineer, they will also guide you, because that will improve the image dramatically. Because what changing the preset to abdominal flow, to the abdominal preset does, it simply automatically reduces the Nyquist limit. It increases the color gain, increases the wall filter to optimize the flow assessment to low flow vessels. So use the cardiac probe, but remember to change the preset to the abdominal preset when you are scanning the kidney. And then again, pulsed wave Doppler, the kidney vessels are small, as I mentioned, and they usually run at the same place, the artery and the vein. So we are not here looking at the artery. I'm not looking to assess the artery. I am only assessing the vein. So the artery will be seen above the baseline. The vein will be below the baseline. if you remember, we talked about portal vein and we mentioned that congestion will have portal vein pulsatility. But for the renal vein, we are not looking at pulsatility, we are looking at continuity or discontinuity. So the normal portal venous flow will be continuous, as you can see here on the left. You might see some pulsatility, but that's not an issue. The issue is that it has to be continuous and not interrupted. You could see the interruption in the middle. There is a pause, a short pause between systole and diastole, and I knew this is systole because it aligns with the arterial waveform above the baseline. And look on the right side, there is a longer pause, and there is no flow in systole, and there is an isolated flow in diastole. And that is what happens in severe renal venous congestion. And finally, this is the protocol together. Again, this is in our paper. You have the summary of the protocol. You have the combination of mild abnormality and normal. This is mild congestion or score 1. If you have one severely abnormal parameter, you have score 2 or moderate congestion. If you have 2 or more severely abnormal parameters, that is already score 3 or severe congestion. And we have also put together this paper which discusses the pitfalls of every single parameter, because any of these parameters can be misleading if we are not aware of the pitfalls. And that's why we put this paper with a group of nephrologists. They are all nephrologists who are now actually leading the way in practicing point-of-care ultrasound of the systemic veins. And again, it's an open access paper, so feel free to scan the QR code and download the paper for your bedside practice. The last thing to say is some of the pitfalls of the protocol overall. Remember that if you have patient with chronic element, chronic cor pulmonale with long-standing pulmonary hypertension, they are very likely to have systemic venous congestion because these patients have high right ventricular preload, and that is important to maintain perfusion and stroke volume. So when I encounter these patients with chronic cor pulmonale, chronic pulmonary hypertension, you should not aggressively correct congestion. You should not try to normalize the portal or renal venous flow or hepatic venous flow, because if you try to do that, the patient might crash, because the stroke volume of these patients is dependent on high preload. So keep this in mind. Always combine VTI with portal, hepatic, or renal vein when you assess decongestion in these patients, and you have to do it slowly. The second thing I want to highlight is that to me, VEXAS or assessment of the hepatic portal renal vein is the RV preload. This is now part of our echocardiographic or echographic report. We have it in our ICU report. We have it in our outpatient report, because this is the right ventricular preload. When I look at the right heart, physiologically by echo, it is not enough to comment on TAPSE or fractional area change or S prime, because these are all reflection of the same thing, which is the output, whether longitudinal or the radial axis or the free wall or the size. But we should also comment on the preload, and this is what we should add, the hepatic, portal, and renal. And we should also comment on the RV afterload, which includes the acceleration time of the pulmonary arterial flow, the RVOT-VTI, the shape of the RVOT envelope. And finally, when you encounter a patient with severe systemic venous congestion, it is very important and essential to keep in mind that when you have VEXAS score 3 or severe congestion, don't give them any fluids, because they are already fluid intoxicated. I don't give them any fluids unless you have continuous hemodynamic monitoring. I am definitely more conservative now when I encounter these patients in terms of fluids. I definitely give more diuretics than before, based on seeing the amount of congestion we have, not only because of fluid administration, but also because of heart failure. When you also encounter a patient with VEXAS score 3, these patients are likely to have resistance to furosemide. So you should try to combine multiple diuretics, whether you want to give spironolactone, potassium-sparing diuretics, if you have a thiazide or acetazolamide, but one diuretic or one mechanism of action will not be enough, because the kidney will be very swollen and the receptors will not be sensitive to a single diuretic. And finally, the last thing I want to say is, historically, we used to fixate on preload responsiveness, but now we have moved towards preload tolerance, which is much more important. It is more important to know when your patient becomes congested and when to stop giving fluids than knowing when to give fluids, because you are more likely to cause harm by giving fluids than by not giving fluids. And I hope the message is clear. And finally, just to highlight the latest book. This is a book published a few years ago now with a group of colleagues in Europe, in the United States, and it provides a structured approach to cardiopulmonary point of care ultrasound. And this is the last work that we did. It's open access. You have the QR code here. Feel free to download it and read it. And it is the European consensus of using echo and ultrasound in cardiovascular emergency and critical care. We tried in this document to provide a practical guidance on using echo in a pathophysiological way to improve the management of patients in our ICU and emergency. I think echo is a lifesaver. There is no doubt that we are far better with echo than without echo, but it's important to know how to use it. And when you know how to use it, you will definitely help your patients have better outcome. Finally, I hope I was able to show you that it's important to use ultrasound in a holistic, multi-organ manner to assess congestion. Now we have lung ultrasound in the guidelines. I remember 10, 12 years ago when we talked about B-lines, people were laughing at us, saying, this is just an artifact. You're imagining these artifacts. I think now they are in the guidelines. No one is questioning the value of B-lines. They are in the ESC guidelines, the American guidelines, and I believe the same will happen with the portal vein. Now we're having increasing amount of data, and hopefully soon it will be established part of the international guidelines for management of heart failure patients. And it's all about this multimodal holistic assessment of hemodynamics. Remember, echography and not echocardiography, because we need to remember to move beyond the heart, to look at the lungs and look at the systemic veins. And thank you very much, and happy to take any of your questions.
شكرا جزيلا دكتور حاتم، محاضرة عظيمة وشيقة وفيها نيو انفورميشن. يمكن أنا أول واحد هسأل أو هعلق، أقول يعني أنت بتنصحنا we shouldn't rely on the CVP only to assess the congestion. We have to combine with portal vein or hepatic vein, especially in the presence of tricuspid regurg or pulmonary hypertension. Am I right?
Yes, Prof. We should not only rely on the CVP, we should use Doppler. Absolutely. So we should not stay at the IVC or CVP, because if you have tricuspid regurg, your IVC will be dilated, your CVP will be increased, but you might not have congestion. And that's why it's important to assess organ congestion. And the best parameter will be portal vein and renal vein. Portal is the easiest. So if you want to do it quickly and you have no time with your patient, just do the portal vein. But if you have time, it is better to do hepatic, portal, and renal.
Now we open paper or lecture for any question or comment from the audience.
أيوة